Welcome to the Helen Bader Foundation CBRF Caregiver Training Program. This unit is on the management and administration of medications in the CBRF. It's divided into a number of parts and videos. This is part 5, Medications and Dementia. As a caregiver, it's important for you to have a basic understanding and knowledge of how drug therapies work and how they're used in dementia and in patients who have dementia-related emotional and behavioral disorders. I'm Maren Meyer, and I'd like to welcome you to the second half of this unit. By now you should be feeling pretty good about yourself and the amount of information that you've both learned and learned more about. My interests include helping people become great problem solvers so they can lead more satisfying lives and provide better care to their residents. We will start this part, as we have started the others, with a pretest. The pretest and the post-test are identical. The questions are designed to help you establish what kind of information you have going into the program and to tell you what kind of information we hope that you'll learn from the program. That won't be all the information we hope that you'll learn, but it'll be a good sampling. So at this time, I'd like for you to stop the video, complete the pretest, remembering that it's not graded, it's just for your benefit, and then when you're done, start the video. In part 5, Drugs and Dementia, we're going to cover emotional and behavioral support before drug therapy is tried. We'll talk about resources for treating dementia, approved medications for dementia, psychotropic drugs and the CBRF regulations for them, and we'll show a sample psychotropic effects monitoring and documentation sheet, and we'll talk about psychotropic drug classifications, what those drugs do. We'll discuss again what anticholinergic side effects are, and we'll talk a little bit more about the motion disorders called extrapyramidal side effects. Finally, we'll talk about psychotropics and their use for challenging behaviors. Remember that in this part, in this video, I'll be using the words medication, medicine, and drug interchangeably. Feel free to take notes anywhere throughout your workbook. Stop the video if you need to. So let's talk about medications and dementia. It's important that individuals be offered emotional and behavioral support before and during any drug therapy that's being used for dementia. It's always important that they've been assessed very carefully by someone knowledgeable in the field. For example, when we look at the physical and emotional health of the resident, maybe medication is a factor in making the behaviors worse. Maybe all of the unnecessary medications have not been eliminated. It's important for us all to realize that the fewer medications that a resident is on, usually the better off they are. So it's sometimes better to be on a slightly higher dose of one medication than to be on low doses of 2 or 3 different medicines. We want to know if the resident is behaving in a particular way because of impaired sensory problems, for example, their vision or their hearing. Do they have a psychiatric history? We have a list here of things that you really need to evaluate. Maybe the resident is behaving in a challenging way because he or she is just exhausted, has not been sleeping well, or is in a lot of pain. Maybe there are social stressors. The individual may have a roommate, which might be a very unusual situation for them. So we look at their environment. Often the individual who has dementia needs a very orderly, well-defined, and uncluttered environment. It has to be suited to their impaired senses. They have to be able to tell where the floor ends and the wall starts, for example. They have to be able to identify the doors and windows clearly. When residents are taken out of familiar settings, they have a tendency to be more agitated and confused. So the more familiar and routine the setting is for the resident, the better off they're going to feel. Sometimes an environment can be too stimulating. For example, if a caregiver decides to play the radio, it may overstimulate residents with dementia. You need to focus too on the task that the resident is doing or being asked to do. Sometimes a task needs to be broken down into more steps. It may be presented in too complex a way. It may be that it hasn't been adjusted for their impaired abilities, either physical or sensory. And if it's an unfamiliar task, you simply may be frustrating the resident. How is the resident communicating, both between him or herself and the other residents and with the staff? Is the resident being approached appropriately? Perhaps another demented resident is approaching the agitated resident from the rear and thereby frightening or angering the resident. Do you understand what the resident is trying to say? And if not, have you taken the time to just sit down and attempt to form some kind of a communication or a bond between the two of you? It may be that nonverbal communication is adequate, or if you ask simple yes or no questions, that the resident will be able to communicate more effectively and thereby be less frustrated. Under B, we have resources for treating dementia. When an individual has emotional or behavioral symptoms that are associated with dementia, the resident's physician or family might want to contact a geriatrician who's skilled in working with people who have Alzheimer's or other dementias. Likewise, the local chapter of the Alzheimer's Association is a very good support, both for families and for residents and patients. And there are local dementia networks and support groups. Approved medications or drugs for dementia. Currently, there are only 2 medications that are approved for treating ongoing dementia. One is Tacrin or Cognex, and the other, donepezil, is Aricept. These are the only ones that are approved by the FDA. There are studies on new drugs all the time, particularly for this kind of a disorder. And these medications are used to treat the symptoms of impaired memory and reasoning, where people's judgment is impaired, where their language skills and communication is decreased. Now, the problem is that these medications are only for the treatment of mild to moderate dementia, and they don't stem the progression of the disease. So as the disease progresses, the medications will become less effective. But hopefully, research will turn something up soon. Psychotropic drugs and meds and the CBRF regulations. Psychotropic meds are used frequently in the management of emotional and behavioral disturbances in demented patients. Psychotropic meds accumulate with repeated doses, and the side effects include sedation, depression, falls, and incontinence, as well as motion disorders that are similar to Parkinson's disease, and they may make the ability to comprehend information more difficult. The state of Wisconsin's Department of Health and Family Services says this about psychotropics. Psychotropic medication means an antipsychotic, an antidepressant, lithium carbonate, or a tranquilizer or any other drug used to treat, manage, or control psychiatric symptoms or disordered behaviors. The resident has a right to be free of both seclusion and restraints. So it's okay to use psychotropic medications to treat these challenging behaviors, but it is not okay to use these medications in the way that's specified here under B1, which is simply for discipline or convenience and not to treat medical symptoms. When a resident is on a scheduled medication that is a psychotropic, it's not necessary that their PRN psychotropic medication be the identical category or drug. But no PRN medication that is a psychotropic can be given without the scheduled medication being ordered. When a psychotropic medication is prescribed for a resident, we have a list of things that the CBRF must do. Prior to administration of these drugs, the entire staff must be informed of the potential benefits and risks of that particular kind of medication. This is very important. And they must also ensure that the resident is assessed on a regular basis, at least quarterly, for desired responses and for possible side effects. And that's information that you can be keeping in your routine progress notes so that when the quarterly assessment comes, all you have to do is review your notes and you can make your report. You need to document these required steps in the resident's medical record. Now, with many psychotropic medications, there's a possible 4 to 6 week delay between the onset of therapy and the onset of the desired therapeutic effect. This means that you will have to have patience and restraint because caregivers will just be seeing a continuation, in many cases, of the challenging or agitated behaviors, and they'll be seeing side effects from the medications long before they'll see the therapeutic effect. The tendency is for us to all grow impatient and say, well, this must be an inadequate dose. You really need to give a particular dose an adequate trial. So try to find a non-drug method of coping with these side effects or adverse effects and allow the drug a chance to work. Under E, we've provided a sample psychotropic drug documentation. It's a simple method of recording the effects of the psychotropic drug, and it has all the required input here. At the top, it says psychotropic medication documentation. You would list the drug that's being given. Here we have the days of the month. The behaviors being treated are specifically mentioned. So in this case, we've used hitting. It might be biting, it might be striking out, might be scratching oneself. And below each date, each person who works on that particular date would show how many times the behavior occurred on their shift. Then they would initial. It's really important to keep these behavioral monitoring sheets up to date. An incomplete record is almost as good as no record. I need to know if I'm going to help you how frequently behaviors happened and when they happened. For example, most residents will have a particular time of day that is much more difficult for them. Sometimes simply by having them lie down at that time or by changing their environment, making the environment more structured or more quiet, we can eliminate a lot of their difficulties without adjusting the drug dose. CBRF owners and managers should refer their questions on these issues to the licensing specialist. And you can also go back to Part 1 of this unit and review the regulations there. And you can have those in your hand when you call the licensing specialist if you do have questions. Under F, we have a listing of psychotropic drug categories and particular drugs by both brand and generic names. Easy for me to say. That includes the anti-anxiety drugs, the antidepressants, the antipsychotics, and the sedative hypnotics. Other drugs that are being used to affect or control behaviors, including drugs that are anticonvulsants or, for example, propranolol, which was originally used just for blood pressure, those medications, because of their use, must also be documented. Under G, classifications of psychotropic drugs. The first one is the heterocyclic antidepressants. Isn't that fancy? The heterocyclics are the older antidepressants. Some of them are tricyclic antidepressants, and you've probably heard of those. Those are amitriptyline, imipramine, nortriptyline, norpramine. They're not addictive, and overall they are less expensive than the other kinds of antidepressants. But it's important to remember that they should not be discontinued suddenly. They need to be tapered. The dose needs to be tapered off gradually. Otherwise, a very unpleasant syndrome can occur in which you have just the reverse of the anticholinergic effects. And the anticholinergic effects are listed under C, being low blood pressure, urine retention, constipation, rapid heartbeat, and sedation. Under D, there's a listing of different drugs that are in this category and some of the brand names. And in this category, particularly effective drugs have been found to be desipramine and nortriptyline. These drugs can be measured, the effective range can be measured in a blood test, and that is an advantage for them because then we can see if the drug is effective within the therapeutic range, or if we've maintained the therapeutic range for 4 to 6 weeks and we've gotten no results, then we know we need to go to a completely different drug category. The second category or subcategory is also antidepressants, but they're called the selective serotonin reuptake inhibitors, and that's abbreviated SSRI. And that group includes the Paxil, Zoloft, Luvox, and Prozac. These are generally more expensive, but they may produce significantly fewer side effects. And they do affect the liver metabolism in the frail elderly, and they affect the liver metabolism of other medications that elderly people tend to take. They have side effects which are quite different than the heterocyclic antidepressants. Those include nausea, headache, and drowsiness. But they are very effective in elderly people, and they are now considered the drugs of choice for depression in older people. As a reminder, we always start these individuals at a lower dose and maintain that dose for a longer period of time before gradually increasing the drug dose. Again, you don't want to suddenly discontinue those drugs. Under 3, we have the other antidepressants. And one of those in that group is trazodone or Deserel. That is often used in combination with the SSRIs like Paxil or Zoloft because it causes significant sedation. And it's used to help people get to sleep while the SSRIs are beginning to work. It's also fairly good for anxiety. There are several others in this category that have a combination of side effects of the SSRIs, which is the nausea and headache, and also the anticholinergic side effects. So for me, those are not the primary drugs of choice. We seem to come back to the antipsychotics in every part of this unit. The antipsychotics should primarily be used in residents with dementia who are experiencing either delusions or hallucinations that are harmful to them or that impair their function or that are causing a safety concern for themselves or for other residents. If a delusion is not harmful to a resident, there is no real reason to treat it. These should be started at the lowest possible dose. They need to be both started and discontinued gradually. And they do encourage sleep by eliminating the anxiety and agitation that these individuals are experiencing. We have a list of all the drugs in these categories. Under F are the drugs that have been found to be most useful in the elderly. As previously mentioned, this group of drugs represents a very high risk for elderly people because of the motion disorders, because of the sedation, and because of the change in blood pressure. And they do have appropriate uses, for example, for the hallucinations or the psychotic symptoms, but they should never be used as a chemical restraint. Under 5, sedatives and hypnotics. Normally, these are avoided in elderly people. Sometimes we use them on a short-term basis. For example, if an individual is just coming into a facility, their surroundings won't be familiar and they won't sleep well, and being sleep deprived will make them more agitated and make their lives miserable. So we can use them on a short-term basis, but normally we do that at a lower dose than with other adults. And we use drugs that don't accumulate as much. So we tend to use lorazepam, oxazepam, and temazepam. And those are numbers 6, 7, and 8 in your list. The sedatives and hypnotics that are listed as barbiturates, we try never to use in the elderly patient. Phenobarbital is still being used in some patients who have seizures, and it's being used as an anticonvulsant. The trend now is to change those people to a different anticonvulsant. These drugs have a very long duration in the body, and they tend to cause great confusion and create more problems than they solve. When we're looking at a problem with insomnia, we use these medications. And sometimes it's important to remember that while physicians may try to avoid the benzodiazepine sedative and hypnotics, they are a viable alternative to the use of antipsychotics when an individual is very agitated. They do, of course, increase the risk for falls, though. Under number 7, there are actually, I think, a couple of anti-anxiety products which are not benzodiazepines and also not barbiturates. Currently, the only one in the United States is buspirone, and it takes 7 to 10 days to act. So sometimes it's given with some lorazepam to help the anxiety for the first 7 to 10 days. It's somewhat chemically irrational to use this drug on a PRN basis because it requires a steady level in the bloodstream to be effective for anxiety. It is sometimes not as effective in people who have had a very good response to drugs like Valium in their younger years. Number 8, mood stabilizers. The prototype in this category is lithium. Lithium is a mood stabilizer that is used to treat a condition called bipolar disorder or manic depression. Other drugs that are approved for that condition include Tegretol or carbamazepine and valproate or Depakote. These drugs can build up very easily, and they do interact with everything from diuretics to warfarin. So they need to be used with considerable monitoring. However, an individual who is on a mood stabilizer for manic depression will probably need to be on that or some other related medication for a lifetime at this point. So it's not reasonable to be weaning people off of that medication. They should be on the lowest effective dose. And those drugs are all monitored with blood tests. Beta blockers, and that's the propranolol I mentioned earlier, beta blockers have been used by some physicians with some success. Normally, I've seen them used with an antipsychotic and with trazodone for extremely agitated people or extremely combative people. They are fairly effective in some people, but because of their mode of action, which is to slow the pulse rate, they can affect blood pressure, and they can also cause cool extremities, which in an individual who has poor circulation can be something of a problem. In the case where you're giving propranolol, regardless of the reason that it's being administered, a daily pulse is a good idea. And that's something that you can just add to your medication administration record, so that you would monitor the pulse and then administer the medication. Let's talk about anticholinergic side effects again. Many of the drugs that are used to treat both emotional and behavioral disorders are drugs that have anticholinergic side effects. And at this point, you probably have these memorized, but I will remind you that they include memory loss, confusion, so they may actually worsen the condition for which they're being used. They can cause agitation and excitability. They dry the mouth and can cause eating problems as a result. And as I said before, blurred vision, urinary retention, constipation, and fall in blood pressure. So all of those things need to be considered, particularly with drugs like the older antidepressants and the antipsychotic drugs. Under I, we've only touched in the past on extrapyramidal symptoms. Particularly the antipsychotics cause extrapyramidal symptoms. The extrapyramidal refers to a particular part of the brain that the adverse effect is caused in. And these are motion disorders that include a feeling of restlessness where an individual will have to pace. And I have seen people who are being treated with antipsychotic medication for pacing, which, by the way, does not respond particularly well to antipsychotics, who then become more aggressive in their pacing. It can cause muscle spasms, stiffness and rigidity, and changes in gait that are similar to the Parkinson's type shuffle. These are not just physically disabling, but they're also socially disabling. They make people appear abnormal or weird. And to use these medications inappropriately then is a double disservice to the resident. So if we look at psychotropics and challenging behaviors, in some situations it is appropriate to use medications for these challenging behaviors, but there are a number of other alternatives. And we've got a list which is just the beginning of a list. I'm sure that from your own personal experience you could add to this list and share that with other caregivers. But anger, many residents who are demented cannot express themselves well. They become very angry and very frustrated, as I probably would, being a very vocal person. Anger is probably best treated by identifying the issue that's causing the anger and eliminating the source of that. If the anger is causing dangerous behavior and all other measures have been exhausted, then it is reasonable to use a psychotropic medication. The hallucinations and delusions that sometimes occur in demented individuals are often successfully treated with antipsychotic medication when those conditions are a problem for the resident or a safety concern for other residents or staff. Before using the antipsychotic medication, someone needs to sit down and very carefully rule out all other contributing factors. For example, some people develop hallucinations as a result of toxicity from some antibiotics, or they may develop a hallucination or temporary delusions related to infections. So it's very important to rule out all of those things, because an antipsychotic on a scheduled basis, as I said, is a long-term commitment. In order for the therapeutic effect to be seen, you need 4 to 6 weeks. Suspiciousness and paranoia sometimes responds. Often people, as they become more demented, will progress through this stage and the problem itself will go away. Pacing is usually not treatable with any of these medications, and if you have an individual who paces, you may just make them fall if you give them medication to stop them from pacing. A lot of times you need to sit down and evaluate, is the pacing more bothersome to me or is it more bothersome to the resident? If the resident is not able to eat enough calories to sustain themselves because of their pacing, then a medication might be reasonable to try. Screaming and verbal noises don't generally respond well to medications. And it's important that you keep in mind that a lot of these individuals are losing contact with the outside world. There isn't a lot of method that they have to communicate. So sometimes people will appear to be yelling when they think they're talking to you, and it simply is their last recourse as far as oral communication goes. Repetitive actions, for example, coming to you and saying, where's my mother, where's my mother, where's my mother, those kind of things, or a repetitive action of picking something up and moving it, and picking it up and moving it again. Those kind of things very rarely respond to medication therapy at this point. Combativeness may or may not respond. You do want to remove any of the instigating causes, any causes, underlying causes that you can remove. Be sure to do that. But if safety is an issue, then you can try a medication. I always would rather see an anti-anxiety drug tried as the first choice instead of an antipsychotic, simply because of the relative risk from the side effects. Let's end part 5. This has been a very serious unit on drugs and dementia with the post-test. Remember that the post-test questions are the same as the pre-test questions. You're not going to be graded on your responses. We'll review the correct responses after you've completed the post-test. So stop now, complete the post-test, and then come back. Welcome back. Let's look at these answers. Part 5, drugs and dementia. Number 1, emotional and behavioral support. Matches C, should always accompany any med or drug therapy. 2, the Alzheimer's Association. That matches F, is a dementia resource. 3, HSS 83 CBRF regulations specify J, specific documentation of psychotropic med or drug effects. 4, repetitive actions of a resident with dementia, H, usually do not respond to a med or drug therapy. 5, extrapyramidal side effects. That matches A, stiffness or rigidity, which may or may not be reversible. 6, Paxil and Zoloft, matches B, antidepressants found particularly effective for elderly with depression. 7, started in small doses. E, in the elderly, psychotropics should be. 8, hallucinations or delusions, matches I, are usually treated with antipsychotic drugs or meds. 9, medications, drugs, environment, the task, communications. D, These are all possible causes of emotional and behavioral symptoms associated with dementia. 10. Anticholinergic side effects is G, confusion, agitation, decreased production of saliva in the mouth. This concludes Part 5, Medications and Dementia. Thank you very much for joining me. It's been nice being with you.